Hi, my name's Daniel Counihan, and I'm going to be a rising junior at St. Ignatius High School, working in my internship this summer was in radiology. The title of my project is Dosimetric Effect of Patient Rotation Under External Beam Radiation Therapy of Gynecological Patients. To do this project, it required the use of a radiotherapy called an IMRT, or intensive modulated radiotherapy, which unlike conventional radiation, uses a precise high-dose beam of radiation. It's used to treat a bunch of different types of cancer, including head and neck, prostate, central nervous system, gynecological, breast, lung, thyroid, and even certain types of sarcomas. For IMRTs, accurate positioning of a patient is essential for an IMRT treatment, because if you're even off by the slightest increment, you'll end up radiating normal tissue, and it's very easy with an IMRT to miss the tumor, unlike with conventional radiation. But current technology does not allow for the easy rotation correction of patients because of the slight degree of which you have to rotate them to sometimes even the 1/10 of a degree. The purpose of this experiment was to determine whether or not the rotation of a patient with gynecological cancer would significantly affect the amount of radiation from an IMRT given to the clinical target volume, or CTV, the planned target volume, or PTV, and the lymph nodes. Me and my mentor, Dr. Yu-Nai Chang, hypothesized that the rotation would not significantly affect the delivered dose, but there may be certain exceptions where it is significantly affected under certain conditions, varying from the amount of the margin between the CTV and PTV, or the weight of the patient, which may sometimes adjust the table without even meaning to. To do this, we took 43 patients with either uterine or cervix cancer, and using the Pinnacle software, the dose was calculated and then exported to a program called MIMVista, which is used highly in the dosimetry laboratories to obtain the isocenter, or what the patient is rotated on or rotated around. The delivered dose is accumulated with the patient rotation data for each of the treatment fractions. Unlike conventional radiation, with IMRTs, you have to give the dose in fractions or in small increments instead of giving it all at once. And once you have that delivered dose, that was then exported as well to the MIMVista. So you had the original plan and the rotated on that MIMVista station. Using the MIMVista, we were able to calculate the DVHs, or take the DVHs, or the dose histogram values, or pretty much it gave how much, or what the volume of the tissue was being radiated at different percentages. And we took that for both the rotated and the planned, and then outputted that onto an Excel spreadsheet to find the D100, D99, and D95. Now, the D100, D99, and D95 are separate values. The D100 is that last value at which 100% of the target dose, when 100% of the target dose is radiated. And then the D95 is when 99% of the target dose, and D95 is when 95% of that target dose. And then the percent differences between the rotated and planned D99, D100, and D95 values were calculated. And then looking at these values, we determined that the D99 and D95 values were significantly affected when both of those values had percentages greater than 2% or 1%. So when you're looking at the data, you originally are looking at CT scans with contouring around the clinical target volume, which, as you can see, is in lime green, the planned target volume, which is in light blue, and the lymph nodes, which are in yellow. When you put those into the MIMVista station, it gives a layout of how the dose will look on that CT scan without all the contouring, without all of the actual imaging. It's just a picture of what the radiation getting with the higher the dose, the more red the color. So you can see that the rotated for this certain slide was a lot less dose given to a majority of the tumor and majority of the normal tissue, as where the planned was a much higher dose, this obviously being one of the more significantly affected patients. And then using those results, we put them into a histogram to see what the dose differences would be. And if you look to the right-hand side of the histogram graph, you can see for the D99 and D95 values for the CTV that there were an up of 7 patients with a dose difference greater than 2%. And then for the PTV, which you had doses above 2%, about 10 or so, which told us that there were some patients. But these patients, when you were to transfer them over and figure out which patients would end up being the same, being 2% or 1% for the CTV and PTV and lymph nodes, it would only come down to 3 patients, whereas 1 or 2 patients might be extremely different or an extremely high dose difference in the PTV, but not the CTV or lymph nodes or any combination of those. And then looking at the DVH graphs, you can tell for most of the patients which were not significantly affected, you can tell by looking at the change in the DVH values that they were almost identical to the planned, and so the planned and rotated were almost identical. But there were a couple of patients which, as you can see, were significantly affected, where especially the CTV would come down to be a lot less of a dose given to a majority of it, whereas the rotated would be a lot, the planned would be a lot higher of a dose. So when we looked at the data and analyzed it, we realized that the majority of the 43 patients, about 40 or so, were not affected. But when you looked at it, about 3 of those patients had been significantly affected and had major changes in the CTV, PTV, and lymph nodes, which comes out to about 7%. And when performing these tests, at the end, we decided that when you're going through these from the start, one thing that you need to consider when you're looking at these values is you have to look at the weight of the patient, which can possibly tilt the table, and also these expanded margins, which if they're too small, then when you rotate it, then the CTV is going to have a lot bigger of a dose difference or dose given to the area that you need it to, which becomes very dangerous for the patient because you end up radiating a lot of normal tissue and sparing a lot of the tissue that had a tumor in it. So if I were to do this experiment again, I would probably repeat it, but keeping the standard margins of 0.7 centimeters between the CTV and PTV, because a PTV is just an expanded margin. It's not anything separate. But 0.7% is also the regular accepted value for most people in dosimetry. And also, I would try following the exact same experiment with those expanded values, but instead of looking at the CTV, PTV, and lymph nodes, I would do the study using multiple cancers, looking in multiple areas of the body, and also looking at the normal non-cancerous tissue and see how much that is affected, because that's also something that you have to take into effect. Because if you radiate too much of the normal tissue, you're going to end up, the patient's going to end up with a lot of side effects that they're not going to like to deal with, and it could even get as bad as death. For this presentation, I would like to thank my mentor, Dr. Nai-Chang Yu, Nadra Sterling, who was one of the facilitators of the program, Rosalind Strickland, who was the head of the program. It's her birth child. She made this all for us possible, and the Office of Civic Education, which ran the program.